So first of all, thank you very much for inviting me to present our study, and really a study that explores the feasibility of a respiratory metagenomic in a clinical setting. This is my disclosure and some information about funding and ethics. Pneumonia is the leading cause of infection-related hospitalization, but the diagnostic tools remain inadequate, often leading to misdiagnosis or delayed diagnosis and an overuse of broad-spectrum antibiotics. We know that metagenomic sequencing for respiratory infection not only offers a benefit for the single patient's individual, but also for infection control and for public health. And I think nowadays in the literature you find several case series, some prospective studies, and review really showing the utility of this technology. Ourselves have been working on metagenomic and application in a clinical setting for a few years. And our recent publication did look at the implementation of the respiratory metagenomic in an ITU setting. But in this work, the workflow that we use solely focused on DNA microbes, leaving out RNA viruses. We identify these and other areas of improvement, and we develop a unified respiratory metagenomic workflow, which then used in this particular study. So what the aims of this pilot work was, of course, the feasibility of the assay in a diagnostic setting, including maintaining the rapid turnaround time that we had shown in the previous study. Performance characteristic, not only for bacteria and fungi, this time for viruses, and the application in different respiratory samples, and of course looking at the clinical impact. So respiratory samples are taken from patients in ITU, and the samples get requested on discretion of the ITU physician to have a respiratory metagenomic done. So the sample, which is in the second panel, you see the sample received in the microbiology lab is then split. One part will go through the diagnostic routine microbiology assays, and the rest goes to the respiratory metagenomic workflow. Our workflow is able within 6 to 7 hours to give back a result to the physician, and this 6-7 hours does include the 2 hours sequencing. The beauty of having a rapid detection of both bacteria, fungi, and viruses in one single test and in one sample can really be appreciated if I can illustrate to you how stepwise the routine laboratory, microbiology laboratory works. So very quickly, so you have a patient coming in ITU with pneumonia, several respiratory samples are taken. These get split in a different laboratory within the diagnostic, microbiology. For culture, you have virology for multiplex PCR. We also use external laboratories if we want to investigate further other possibility of being the cause of this pneumonia. The patient also gets more samples taken. This time could be the urine antigen for Legionella or pneumococcus, and so on, a blood test if invasive candidiasis or aspergillosis is suspected. So now going back to the respiratory metagenomic workflow, in this slide just summarize how the sample is worked through in this method. We have, so the first part, you have the sample broncholavage gets centrifuged, and this allows for depletion of part of the human cells by discarding the pellet. The supernatant is a further process, and this time is a mechanical bead beating that allows the lysis of cells, the release of nucleic acids, which are then digested, and the remaining RNA and DNA is then extracted with, in our case, was an automated extractor. We go on to have a reverse transcriptase step, second synthesis PCR, and then finally ready for library prep with a rapid kit and sequencing with a gridiron. We know how important it is to have a good method that can have a DNA depletion step, because this will increase the sensitivity for detecting our microbial reads. So we wanted to see how good is this workflow to obtaining this. And we've done this by testing per aliquot or 3 broncholavage that went through with and without this human depletion, DNA depletion step. And you can see how in all cases we had, as expected, a decrease of human DNA detected reads and an increase on microbial reads as the absolute number and percentage. We then needed to establish a threshold. This is for reporting a clinical significant bacteria. And we did this by looking at bacteria sensitivity and specificity at different threshold of microbial abundance in our report, at 30 minutes of sequencing, 2 hours, and 24 hours. And if you look at 1%, you can see an increase in sensitivity. We had 30 minutes, 81%, and go up to 94% after 24 hours, maintaining a very high specificity. And this we did within calculating a ROC curve analysis, so comparing with diagnostic microbiology assays. We did the same for viruses, but this time we didn't take the threshold, and but we look at absolute number of reads. So if you look at when we detected one viral read, we had a sensitivity that went from a 77% at 30 minutes to a 92% at 2 hours of sequencing to 94% at 24 hours of sequencing. Therefore, we took one read as our threshold to maximize our sensitivity. We are doing this in a diagnostic setting. Extremely important to have these quality controls. So in internal control, we use TMV, tobacco mosaic viruses. So this is important for inhibition and was spiked in all our samples. We had a commercially available positive control, which included the bacteria, DNA and RNA viruses. And as a negative control, we use a respiratory swab matrix, which also was spiked with our internal control. And briefly now, we go to our results. So we carried out this test for about 4 months, and we just recently completed. We had 113 samples from 73 patients. The failure rate, where failure rate means our internal control was not detected in a negative sample, was about 6%. The majority of tests, we were able to give a result within the same day. And if you think that we started the process at 9 o'clock, by 4 o'clock, we were able to give the result back to the clinician, and this includes these 2 hours of sequencing. We were able to do different sample types, although the majority was a broncholavage. And only in 8 samples, we had a further detection following an overnight sequencing. So how did we do? How was our performance per sample compared to the diagnostic and reference and microbiology assays? For bacteria, we had a sensitivity of 98%. We had a mixed E. coli, a very good specificity of 95%, which is really similar at validation protocol that I shown you before. We also had the ability to detect some of this antimicrobial resistant, and it's really important to do that. But in our set of samples, we didn't really actually have enough to give you the sensitivity or specificity for this. We had only a couple of samples with antimicrobial resistance. For fungi, we had a sensitivity of 93%, and we missed one candida, and a specificity of 99%. This is also data that was not present in our validation set. And so indeed, this workflow performed very well for fungi as well. What about viruses? We had a sensitivity of 80%. We did miss 3 viruses, but all 2 of them are really at the limit of detection of the PCR with the CT above 35, and even the other one is the limit of detection for our sequencing with a CT of 28. We also had a very high specificity, and really this is very similar to our validation set that I've shown you before. We are still waiting for some result. Regarding viruses, we also wanted to look how good is the recovery of the whole genome. And we did pretty well when we have at least 10 reads per virus. The coverage of 5 times death at a median of 85% goes from 67 to 100%. And if we take one of these, for example, we had an RSV with more than 500 reads and a very good coverage at 10x, we were able to build a phylogenetic tree. And the importance of this in a clinical setting is the possibility to use this for outbreak investigation, as we did in the past for SARS-CoV-2 or genome sequence. Now, really a couple of cases that just to show you this assay in real time. We had a case, it's a 64-year-old man, was admitted in December with a community-acquired pneumonia, then had a very long stay in the hospital, had developed pulmonary embolism, several boosts of pneumonia, hospital-acquired pneumonia, deteriorated, admitted to ITU. I did a CT, also showed a mediastinal mass. Of course, high in the differential was TB, but had several tests already done to exclude this. We had a sputum that was negative for aramine and culture. Also, this mass was biopsied, sent for histology and also for culture. And none of this really supported the diagnosis of tuberculosis. But then they sent to us a sample when in their differential diagnosis, the TB went down the list, and we indeed detected mycobacterium tuberculosis. And of course, then this sample was then sent back to the diagnostic lab to do the test for TB and was confirmed. But I just wanted to show this because really it's the value of this pan and targeted approach that is really of clinical value. The other case is a case of a 32-year-old female was recently diagnosed with lupus, an autoimmune condition, and had what is called the catastrophic phospholipid syndrome, i.e. many clots given throughout the body and causing multi-organ failure, requiring transfer for support to our hospital. The send bronchial lavage, we were doing this pilot study, and we detected an acute parvovirus. Parvovirus is not per se respiratory infection, it's transmitted through the respiratory droplet. And the way that we, in the laboratory, we confirmed this from serology and finding in the blood. Soon after this case, we had another case of detecting an acute parvovirus. And although in both cases, this finding doesn't really change the management of the patient, I think highlight how his technology can be used as sentinels of a public health problem that are ongoing. In fact, a few weeks ago, actually 1 week ago, we received this from Public Health England of an increased parvovirus circulation for this year. So to conclude, it is feasible, yes. We have shown the feasibility of this. We had a low failure rate. We have a very good turnaround time. The clinical impact, we are investigating a little bit more and is not completed. It looks like we do actually have at least a 20% changes in antimicrobial usage. Can we implement, are we there? Can we implement this in a clinical setting, in a diagnostic setting? We've done this validation. The laboratory workflow is pragmatic, can be done. we have a very good quality control, and we might need to work a bit on tweaking the bioinformatic pipeline to be in accordance to the ISO accreditation. Ideally, we would like an automation of this, but I think we are ready to establish this as a diagnostic test. Of course, this will be nice to have this replicating in a multi-site trial. To have a health economic is also something that you look for implementing new tests. And we are looking forward to apply this in other sterile sites. Before finish, I just want to thank the wonderful team that I work with, in particular Luca and Adela and Jonathan that supported us throughout the years. Thank you very much.